guide you throughout your career. The first stand for the 4C principle. Is anyone familiar? Right, the 4C principle. The first C stand for apa dia? Condition, right? Condition, this is something that you better look from the patient, be it from your history taking or either from your physical examination. Your condition, what condition this patient has. This is something that you need to ask yourself. Then you perform a physical examination or you perform your plucking with the intention to establish what is the condition. The second C stands for cause, right? Simple je, cause. Say for example, you have a case of patient presented to you with shortness of breath. As simple as that. So back in your mind, you need to ask yourself, why this patient developed shortness of breath? As simple as that. Is it because of respiratory illness, or is it because of cardiovascular disease, or is it because as simple as anemia, or is it because of patient has gross ascites that causes springing diaphragm, causes the lung fail to expand properly, then leading to shortness of breath, right? So these are the things that you need to establish from the second C, the cause. And sometimes the cause can be multiple also, right? You can have multiple causes for one particular condition. I give you an example of a case of heart failure. For example, I mix up between the short case, long case, because this is very much a principle that you need to carry throughout your career. You can apply this principle in pediatrics, in ONG, in whatever field that you are going to be in later on, right? The cause can be multiple. For example, you have a case of patient presented to you with shortness of breath, right? So back in your mind, when you plug the patient, you know this is a case of a heart failure. Based on the symptoms, shortness of breath, reduced effort tolerance, PND, autopnea, leg swelling, and so on, right? So back in your mind, you want to establish why patient developed heart failure. So there are many causes for heart failure. Sometimes the cause can be multiple. You can have a patient in what, if you're familiar, they put there, they compensate the CCF, secondary to multiple factor, right? Multi-factor, right? First one is non-compliant to medication, non-compliant to restriction of breath. Another cardiac arrhythmia or infection or anemia. These are the known causes for heart failure. So when you do plucking, when you do examination, so these are the things that you need to establish at the end of your plucking or your physical examination. Okay, clear so far? The third C, complication, right? You are not going to be able to complete your assessment if you do not assess for complication. How to assess for complication? You can tahu lah. You can have a good understanding of the disease as well as of the condition, right? The complication can be from the condition, can be the complication from the cause. I give you an example of heart failure also. Let's say the patient presented to you with shortness of breath again. From your assessment, you think this patient has heart failure, acute decompensated heart failure. Secondly, which is the cause, community acquired pneumonia, for example, right? And then what is the complication? Complication can be cardiac shock, can be apa dia lagi? Respiratory failure, type 1 or type 2, right? So these are the complications that you should be familiar. Another example, let's say you have a privilege to do a physical examination to someone with gross features of thalassemia. I have one medical student, two medical students just in last year. Be assigned to examine a patient with thalassemia, and his one student unfortunately do not recognize that this patient has thalassemia, which a complete fit. Another one happy whenever he mentioned this patient is a thalassemia. Even a blind person can know that this person is a thalassemia. Very obvious. Even you touch, I think you can feel because of massive hepatosplenomegaly. Hepatomegaly with splenectomy scar. The facial experience are quite classical. But what the examiner are looking at not only the ability to detect that the patient has thalassemia, but to go a few steps further to assess whether the patient received adequate blood transfusion or not, whether the patient received other features to suggest for iron overload. Then you need to go one step or few steps further to assess for complication from iron overload. So these are the things that the examiner is looking at, right? To distinguish you from a average medical student to excellent medical student, where you manage to get the complication from that particular condition. Another example for the respiratory illness, right? When you get someone, let's say you've been given an instruction to perform a respiratory examination to one person. So you conclude from your examination that this patient has right-sided pleural effusion, right? Right-sided pleural effusion. Then back in your mind, you need to formulate the cause. Why this patient has right unilateral pleural effusion, right? Can be multifactorial. Usually because of pneumonia with pneumonia effusion. Can also be due to malignancy, right? TB with TB pleural, and sometimes because it can also be due to heart failure with unilateral pleural effusion. Usually heart failure you are dealing with bilateral pleural effusion, but sometimes as we progress along, you are seeing more cases of heart failure presented to you with unilateral right pleural effusion, mainly on the right side. Why? If you go back from the literature, you will know why. Right? That's how you learn as you progress further later on, right? And then from your examination, this patient has pleural effusion. You conclude the etiology for the pleural effusion due to pneumonia, and then complication. Complication, you need to look whether the patient in respiratory distress or not, as evidenced by use of accessory muscle, SpO2, as well as you think of ABG if it's present from there, right? So you can see the patient whether in respiratory failure or not. So that complete your, that summarize well your presentation later on. Right unilateral or right-sided pleural effusion, secondary to pneumonia, complicated with type 1 or respiratory failure. So that's complete. Then you confirm. You can confirm by the history taking, physical examination, as well as from the imaging. You confirm the condition, you confirm the cause, you confirm the complication using all these tools. Okay. Okay, that's pretty much. The last C stands for confirmation, right? Briefly, I already go through just now the confirmation. So you need to confirm your condition either by clarify back the history. You need to confirm the cause by the history as well as from the physical examination. Then you need to confirm the complication from the history, physical examination, as well as your blood test or imaging. Okay, that's pretty much about the principle. So far, okay, yeah? So far, okay, right? Okay, what ni 10 minit? Nak denda ke tak? We need 2 volunteers. So last 2 person. Nak panggil volunteer ke tak? So last 2 person tu senyum lah tu. Okay. So for respiratory, next I'm going to focus on the respiratory shock case per se. Even though the chances of you getting a respiratory case for your final 4 is quite slim, but you need to know. Out of 4 systems, respiratory, abdomen, neuro, as well as cardiovascular, respiratory examination consumes a lot of time. Even though the examination is quite stereotyped, quite standard, but it consists a lot of maneuver, right? You have anterior, you have posterior, you have upper, middle, and lower, right? So you have to complete a lot of areas within 10 minutes. Sometimes when the patient, if you get female patient, usually we tend not to give female patient because you might have the difficulty to expose adequately. So we try as much as possible to provide you with a patient, with a female patient who don't mind to take off the shirt, right? Because sometimes susah lah, right? For female you nak examine properly, then you have 2 examiners, so quite difficult. Sometimes the patient might be reluctant, but in real life you have no choice. You have to examine the patient depending on your luck lah, tadi juga. But for exam purpose, so far we managed to find male patient for respiratory cases, and there are not many cases, bear in mind, and we are told or we are instructed to find patient with single or unilateral finding. A single finding only. Either you can get pleural effusion, consolidation, lung collapse, Sometimes you get lung fibrosis. Fibrosis jarang lagi dapat satu findings, usually generalized lung fibrosis and bronchiectasis as well, right? Memang tak pernah masuk pneumothorax, so don't worry, you are going to experience that during your career later on. And then if we do not have enough patient, then maybe you can get two findings, but usually only one findings. Most of the time, pleural effusion and consolidation, because these are the patients that are stable, and sometimes also bronchiectasis, because the findings are quite classic and quite easy to get, right? So that's all. Senang, ya kan? The tricks for respiratory examination, the first thing I think before you your thinking process, right? When you examine from the peripheral, you nampak patient dah ada clubbing. Let's say the clubbing is attributed to respiratory illness. You already down to few lists, right? Clubbing in respiratory illness, there are not many causes. First one can be lung emphysema, right? Chronic effusion can be due to also bronchiectasis, lung fibrosis, and then apa lagi? Lung cancer. So you tengoklah based on the probability, based on the features, which one is more likely. So you have to deduce your final conclusion based on the likelihood, right? Because you are not sure at the end of the day. Sama je, me as a physician, when I manage patient, when I examine patient, when I decide what to do with the patient, sometimes I'm not sure what I'm dealing with. But you have to commit based on the available information, based on your physical examination, based on the history and the blood parameter, what is the most likely diagnosis. You cannot be so certain, right? There is no certainty in life, right? So once you say, based on your probability, like you have a good probability, then commit on that particular aspect, and hopefully you are on the right track, provided your examination technique and findings are correct. Okay, so that's for the principle. And for the respiratory examination, ni abdomen je macam ni, lie flat. Don't be surprised masa exam nanti, if the patient on lie flat, ramai examine patient on supine position macam ni. So your job as a medical student, the first thing, after you introduce yourself, as simple as that, you introduce yourself, you introduce the surrounding, you introduce the lecturers or the examiner to the patient. Because if you look at your rubric of marks being given, there are few rubrics or few domains. The first domain are given to the overall conduct, meaning that how do you perform, how do you behave in front of the examiner, how do you introduce yourself to the patient, right? Your manners and so on. So you will be given a mark based on the overall conduct. Even though your findings are not correct, you will still get marks for the overall conduct. We cannot be biased, right? But the percentage for overall conduct is not as much as from the domain of findings and your presentation. The second domain from your marking sheet of your respiratory, your short case examination is from your findings, right? The techniques that you do, whether you are doing the right technique or not on that particular examination. Thirdly is your findings, whether your finding is appropriate, either you miss any important finding or you create findings. Miss findings much better than creating science, right? So if you create science, then that's it for you. You better not to create. But at the end of your examination, you are too afraid to mention anything because you tak ada findings. So if you do not get any findings, memang you garuk lah, right? So no way we will put patient with no findings. So if you get no finding, then no mark inshallah for you. So that's the principle. So there is no way that we bring a patient with no finding for the short case session. So whenever you get patient, try to look for the signs. The fourth finding or the fourth domains are from your presentation, whether you present nicely or not, or whether you summarize well or not. And the last one, the fifth domain, is your discussion. How do you play around your presentation? How do you discuss when the examiner asks you? This is the part where we distinguish average student to an excellent student. You manage to discuss after the investigation or management, then you know you are on the right track. Rarely, examiner will progress or will proceed to the discussion if the examination findings are not correct, right? So kalau you dah dapat some time to the discussion, then you should be happy. You already at least a pass student already, rather than a fail student. If the discussion mainly about are you sure about the finding, are you sure about the finding, please be informed that your finding is wrong. The examiner is telling you that your finding is wrong. So do not ada keras kepala lah. Do not be so confident, right? Confident 6 months to bagi masa. Right, so do not be so confident. Whenever the examiner asks you, are you sure with the findings, then you better surrender yourself. I'm not sure. Can I have more chance to examine, right? If you are not sure with the findings, you would like to revise your finding, and the examiner prompt you in such a way, you need to be more polite to the examiner. You can ask the examiner, do you mind if I re-examine the patient again so that I can double confirm with the findings? That's it. As simple as that, right? So rather than you stick to your, unless you are very sure you think the examiner is wrong, then I think you are fighting with the wrong person at that particular time. Okay. Okay. So for the respiratory examination, before you touch the patient, you dah introduce your surrounding, the examiner, as well as the purpose of examination. The first thing that you need to do, get consent, right? Masuk consent, you dah explain everything tadi, and then you position the patient. Position, okay, 45 degree. Kalau you are the first candidate, sometimes the patient on lie flat. But if you already the subsequent candidate, the back is already the back is already positioned in 45 degree for you, and then sometimes you tak buka lah. So patient memang duduk 45 degree, depends. But if you are the first candidate, sometimes you are too clueless, tak tahu nak buat apa, and then you tak prop up patient properly. So position the patient properly, 45 degree in all short case examination except for abdomen examination. Jangan terkejut, MAT pun examine patient abdomen sambil duduk, sambil 45 degree. I was so shocked. One master student, when I have a short case session, assessment, not a session, an assessment, doing abdomen examination while patient on 45, no, patient already on supine position, and then he propped up the patient 45 degree. I take a joke. And then sampai ujung examination pun dia continue macam tu. I was so shocked, you know. This is a fatal mistake by the MAT, even though you get the findings, but the principle are totally wrong. Why? You put life flat dalam tu, senang nak palpate, right? So that you can palpate properly. There is no guarding. The abdomen can be more soft, so you get more finding from the physical examination. Okay, so next is after you position, expose, right? You expose adequately. For male, you can just ask them to take off the shirt, right? Dalam exam, I am not during exam, but during the last few groups, I have one short case, respiratory short case with a medical student. I think your batch also last year pun. Do not properly expose the patient. I ingat dah obvious, because you as a student, right, you examine from the patient, right, and that particular patient has a chest tube, a pigtail on the left side, and that particular student, not one person lah, multiple person in the group tu, do not even bother to look at apa kat bawah tu. Dia kata tubing for urinary bag. I was so shocked, right? But it is not the chest tube one. If you been observant enough, the pigtail punya tubing memang looks like macam the urinary bag. So dia bukan macam chest tube, pigtail kecil je. That's why this is very important of proper exposure, proper and adequate exposure, so that you do not miss any important findings, especially on the left side of the patient body, right? Sometimes back kan besar, your hand is so short, you are so short like me. Patient duduk belah kanan, right? So difficult for you nak tengok belah sana, right? You bagi alasan I'm left-handed person lah, tak kira. Always examine on the patient right. You belah kiri pun jangan duduk macam ni. You buat tu complete fail already. So sometimes when patient sit quite far from you, this is the back border. You tengok superficial je, you tak tengok properly, you tak expose properly. Laki perempuan ni. Laki kan, tak pernah main dia. Right. This is the area that we put chest tube pigtail. This is the safety triangle on the left side. So if you do not observe enough, sometimes there's presence of scar over there, thoracotomy scar over there. So if you do not expose adequately, then you're going to miss. Important aspect of the patient position also, let's say kalau kita 45 degree, patient tu ada minimal pure effusion. If you put patient 45 degree, sometimes the effusion can accumulate better in the lower part of the pleura, right? Kalau tengah supine, sometimes you might miss the finding because of the pleuric dekat base, lung base. It's quite difficult to get. So always remember 45 degree. And unlike any other shock cases, any other system, for respiratory, always spend a good time, about 30 seconds, to inspect around the vent, looking at all the oxygen supplementation, sometimes the inhalers, sputum port, and so on. Right, this is very much important. Even though patient doesn't nampak comfortable, but bear in mind that you are going to examine patient in DPSP. There's always a locker there, so make a habit to do a quick inspection, because when you have when you do an inspection, you tengok ada inhalers. It gives you some idea with regards to possible condition, right? So there are not many conditions that require inhalers. So kalau dapat inhalers, is a clue for you or for the patient condition. Okay, check surrounding, position, exposure. You tak pegang patient lagi waktu ni, right? Then you stand at the end of the vent, looking at respiratory, in the respiratory distress or not, the respiratory rate, and then you tengok patient ada blue lip, memang tak nampak biasanya. The chest whether symmetrical or not. This is something that you need to be observant. Kalau you remember, tak tahu lah, yesterday punya group from my respiratory case, ada patient tu memang ada right upper zone consolidation. If you careful enough, you tengok the depression density, nampak reduced chest expansion over right upper zone. Right, you prop patient properly, you tengok the lung does not rise symmetrically. So you know there's something is not right with the patient. The one that does not rise symmetrically usually the one that is abdominal side. Okay, clear so far. Tak pegang patient lagi ni, baru tengok prop up properly. And then baru you move on to the patient periphery. Periphery, there's a lot of things to do, but it's going to be very quick. Most important aspect, you tengok you dah already familiar. Pharma, erythema, your past, everything you tahu, fine tremor, flatting tremor, you already familiar. But something that many students miss, most of the students from my past experience, the HPOA, the hypertrophic pulmonary osteoarthropathy. Even though it's a forgotten sign, I'm not sure how much relevant, but this is something that you need to be familiar with. You need to know how to look for HPOA. Always look for the wrist tenderness. Wrist tenderness as simple as you hold the wrist, tadi pusing tangan dia, and then you maintain your eye contact with the patient. Jangan buat tanya sakit ke tak, sakit ke tak. Sometimes they do not complain pain, but you see the facial changes, the facial expression. Why? If you get this kind of sign positive, so you already narrowed down your probability to view differentially, right? Unless dekat wrist ni dia nampak ada granular, of course dia akan rasa sakit. But if there is no granular, there is no signs of inflammation, but when you press the wrist, it's tender, patient shows some facial changes, then you know that it might be positive. So you already narrowed down to a few things. Okay. The next thing that you need to do is the clubbing part. The clubbing part, I think is important also, very much important in respiratory illness. You're already very good at identifying clubbing, but sometimes the examiner, they like to play around with you, right? They want to test your basic knowledge of clubbing. So the next question, when you have a patient with clubbing, they want to ask you what are the grades of clubbing, right? So you need to know the clubbing grades, and then make sure you grade them appropriately according to the understanding of the clubbing grade. You can do that shamrock punya shape too, or you can just make sure your eye level same with the patient punya pad. Kalau tak nampak macam tu, you can feel the sponginess. Kat tu susah lah, ramai sangat. Kalau short case, backside boleh buat. But for this one, I hope you already have some idea on how to price for the clubbing, the sponginess, the nail bed, right? Assuming you are normal person for clubbing, so there is no less sponginess. But if you do a lot of to the patient, sometimes you might not, the clubbing might not be obvious, especially at the earlier stage. But you can see already there are some changes over the nail bed, already become spongy and so on, right? So that's indicate grade 1 clubbing. So far, okay? Right. And then you move on to the shoulder, looking at the BCD sekarang, but to me it's not very much important. And then you tell for the eyes. Eyes, you check for conjunctiva pallor, okay. Another important thing that students tend to miss is the corner syndrome. Even though it's negative, you already see it, just like the SPOA, but it is something that you need to mention during your presentation. You tak payah nak cakap, tak payah nak buat lebih-lebih lah. Just tengok there is no corner syndrome from my examination. So what are the Horner syndrome? Kita tahulah the three things, right? Syndrome consists of constellation of symptoms and signs, right? So you kena tahu apa dia Horner syndrome. Meiosis, anhidrosis and ptosis, right? Ptosis nampak obvious, usually nampak obvious, and then make sure you know how to explain the ptosis mechanism behind the Horner syndrome. Bear in mind also that everything that you do during your physical examination, you must have a good rationale. You must know the reason behind. Not simply what maneuver for the sake of to complete the examination, right? You kena tahu, you kena justify properly. You must have an explanation for every maneuver. For example, why you check for SPOA, you can explain. Why you check for clubbing, you must explain what condition associated with clubbing. So when you check for Horner syndrome, you must have an idea what condition that can lead to Horner syndrome. What entity, what and what and what. Right? You can ask yourself lah, baru you baca, baru you faham why you perform such maneuver. And then you move on to the looking at the pedal or not, apa tu not so much of an issue. And then you go for the trachea. Right, trachea last year I think the OSCE station was the trachea assessment, right, for medical. Are you aware? So police not going to come up again this year, but this is very important. No, last time as a decade, I think for the year kan I tak ingat orang satu. But the instruction is simply ask the student to perform a trachea assessment. That's it. How do you perform trachea assessment? Senang je, right? Very easy. But if you are not familiar, macam-macam je buat lah. Nak cekik patient lah, nak tahu what's the answer, then that's it for you. So make sure you know how to do. You just press your fingers kat tengah-tengah tu lah, kat trachea. And then you feel the space. Payahlah ramai sangat ni. You feel the space at the end of the bahagian dengan nama ni. You feel the space between right and left. Usually it should be macam equal distance between right and left. If you get one side, more fingers can be put in. Usually the other side is dah reduced. So when you have a displaced trachea, there are two possibilities, right? Either trachea is pulled because of the collapsed lung, or push away because of a mass ataupun massive pleural effusion that push the trachea away. So at least you get some idea already with regards to the trachea. Also from the trachea you can assess for trachea tap, right? Trachea tap quite sensitive signs for your COPD or hyperinflated lung disease. And then boleh problem. Okay. Then you move on to your respiratory examination, the anterior part, right? So before you touch the patient, always make a quick inspection on the lateral part, right and left again, and then check for effect speed. So this is something I have been emphasizing a lot with the medical student. Yes, they can improve another why you need to check for effect speed in respiratory examination, right? What are the reasons? Jangan kelas mana tak payah dah pandai lah. Yang previous class ke yang belum ada kelas ini. Any particular reason why you need to check for effect speed in respiratory examination? Apa dia? so much. You are not looking. Yes, this might be the respiratory illness might cause complication to the cardio, but you have to be more specific. Okay, what are you looking for from the FXP? If it displays, what information that you can gather? What information that you can conclude from a displaced FXP? Uncoagulated now, not so much. Pulmonary hypertension, right? That would be another clue. Another reason? Heart failure usually not going to come up in your respiratory examination. Usually. Apa dia lagi reason? Respiratory, right? Sometimes you cannot feel the FXP on the left side. Make sure ada patient. Last year memang ada patient. Sorry, ada patient. Category syndrome. We bring one patient with category syndrome. Sorry, not during the exam, but so happen during the short case assessment for your end of posting. Tak apalah, tak tahu siapa yang unfortunate last time kena dengan I kat 8S. Tak ingat tak apa kena. So happen that patient was admitted during the time of assessment, right? So dapat patient that show cardiac. So fortunately the student tak make up the sign. Saya kata I cannot appreciate the FXP. Of course can appreciate, but tak ada kat sini. Then I ask him, kat mana? If you do not feel here, then you look on the right side. Why? Because of the category syndrome in respiratory disease, right? You can get patient with bronchiectasis, and then there's cardia that give you a point towards the category syndrome as your diagnosis, right? Bronchiectasis is the main finding, but the cardia, situs invertus is like a typical features for category syndrome. So you kena tahulah why you need to check for FXP in respiratory examination. Okay, clear? Then moving on to your chest expansion. Make sure you know what is the standard chest expansion or the normal chest expansion. Kalau tak tahu, difficult. And then make sure this is something yang important, but you have to do it very, very quick. Right, tak payah spend so much time. Because you remember there's a lot of things that you have to do in respiratory examination. You are doing, at the same time, you are analyzing the signs that you are getting from the patient, right? So, you buat your chest expansion, 3 tempat dia, atas, middle and lower part. You get between 3 to 5 and should be at this speed, right? Then moving on to the percussion, your vocal parameters, right? Sometimes certain textbook prefer you to go for vocal parameters first, sometimes go for percussion, depends lah. I think go for vocal parameters first. What I did in the past, I just use my palm and the side of the my hand here. Guna 2 tangan terus. Kalau buat satu-satu, then patient has to say many times, right? 99, so you waste a lot of time. So better you use your 2 hands, 99. But for me, this is just something that I have to do. I rarely get any finding from my tactile parameters because my hands are sensitive. But make sure your finding tactile and vocal parameters are not contrary to each other. It should be similar. So if you get your tactile parameters is reduced, then you get vocal parameters is increased, I think you better stick to your ear rather than your head, right? I just want to do just for the sake of completekan the maneuver. And then you move on to your percussion. Percussion is very much important. And even you are a left-handed person, I strongly advise you to percuss on using your right hand, using your middle finger. Madam, a few weeks ago pun ada percuss, tak dengar apa-apa pun. Right, percuss macam tu, right. In percuss, make sure you put your fingers in between the rib space. Right, not on the rib, not on the thick muscle part, but on the rib space. So when you put your finger, you have to look for the space as if you are looking. Tak ada letak aja di percuss, tak ada percuss. Meaning that you tak tahu letak kat mana. Sometimes kalau patient tu not skinny, if patient skinny, tak enough, right? You can see the space clearly, but if the patient is quite obese or not skinny, so difficult for you to identify if you do not rotate properly. One tips to save time, few seconds perhaps, Rather than you go right and left, you go right, left, then go down macam tu, buat zigzag. 1, 2, macam ni lah. Okay. Rather than you go one, so you save few seconds of your life. Okay. Percussion. Left-handed person pun, I strongly ask you to percuss using your right hand, using your wrist movement rather than left hand. Nampak very awkward. Nak dipercuss macam ni nampak awkward. Imagine lah nampak awkward. Ni nampak professional sikit. Because you will never be able to examine the patient on the patient left. Jangan ni tak boleh macam I do left-handed person. I examine patient on the patient left. No way. Life is unfair. Okay. Next is your auscultation, right? So auscultation is something that I tengok student you assess two things during auscultation. There are 4 areas, the apical, right and left. Macam ni what? There are few things that you assess during your auscultation. The first one is the quality of the breath sound. Is it increased or is it reduced or is it normal? So what is normal is something that you need to be familiar with. You kena dengar banyak kali sampai you know that this is a normal breath sound. Right? How many types of breath sound there? 2, right? Vesicular and bronchial breathing. Right? I hope at this point of time you have a good idea what is vesicular, what is bronchial breathing. Sometimes the examiner, macam tadi, just like clapping, they just not play around with you. Ask, go back to the basic, right? Go back to the basic. So what is vesicular breath sound? So what is bronchial breath sound? Kalau you manage to impress the examiner, then move on to the next question. Kalau you start there, then that's it. Sometimes we want the student to have a good basic understanding. Kayak sama dengan cardio lah, profesor Gandai, right? If you're familiar, you love to play around with students, right? So sometimes you tanya pasal JBP je. Even to the this is not only to the medical student, but also happen to master student. Year 3, year 2, sometimes when I have class with him, most of the students akan dekat JBP. How do you check for JBP? So what are JBP? How do you check for the wave of JBP? A wave, U wave, B wave, something macam tu. This is the simple but very much important aspect of JBP assessment. So sometimes examiner tidak tengok whether your basic is good enough or not, whether you deserve to be asked next question or not. If your basic is not strong enough, then difficult to progress to the advanced stage. Then you do your auscultation, right? When you do your auscultation, do not move your stethoscope until you completely listen to inhalation, inspiration and expiration. So sometimes the student move too quickly, letak 1, 2 macam tu. Dia tak tahu dia buat apa. Tak tahu dia apa. So dia stand. Take a deep breath, in, out. In, out. Let's say you appreciate abnormal findings, you can listen back to that particular area, no issue. In, out, in, out, in, out, in, out, macam tu. And then 99 also, right? 99 I think tak payah tukar nenek-nenek lah. I think most of the countries here, they are very well versed with the language. Right? So you can just ask them to say 99. It's not a fancy word for anyway. 99 je pun. 99, even those who cannot speak English pun, if you ask them to say 99 boleh. Sometimes patient bisu ke macam mana. But most of the patient can say 99 clearly. Right? So what's so special about 99? Anyone knows? What's so special about 99? Why can't we say 92, 93, 99? Huh? Have you ever think yourself? Or have you ever give yourself a time to think why are we concerned so much of 99 during respiratory examination? Tak pernah cari eh? So interested to know. Simple, right? But you need to know why 99, why not 100, why not 999, why not 9,999, right? So what's so special about 99? I know Muslim dia tahu lah 99 nama Tuhan, right? Ada 99, but that's not the reason for you to say 99 macam tu. Okay, balik pada why 99 so special in to assess for vocal parameters. But make sure you listen with inspiration and expiration completely. And the next thing that you need to do is the way you hold your stethoscope. This is very much important. The stethoscope. Stethoscope. Semua dah ada stethoscope. Right. Jangan kepit macam ni. Jangan kepit macam ni. This is not professional lah macam ni. So always hold your stethoscope for cardio, for whatever mean, for whatever examination. You pegang macam ni. Use your index finger and then your thumb and then one of your hand. You can either hold the patient's shoulder, right? You bagi more comfort to the patient. You can support the side. Kalau dia one of your hand letak kat belakang, susah lah. Contoh example. Satu macam ni. Kepit lah, I tak tahu nak buat apa. Satu cakap pinggan. This is sad to say, but during exam, this is something that you are not realize kot. Jadi spontaneous. When you do your auscultation, biasa ada letak kat your neck macam ni ataupun letak dalam poket, right? Sometimes kalau female tu pakai tudung pula, pakai tudung yang tak banyak. Nanti saya cakap pasal tudung pula. Ini ada isu, buat masa lagi. Bukan kata tak pakai tudung, cuma cara je. So sometimes you put, I think I really advise you to put your stethoscope dekat neck lah, cepat sikit, so that easy for you to just take off your stethoscope and listen to the patient. If you put dalam your pocket tu, sometimes you nak keluar terlekat dah, lepas tu jatuh pen pula lepas tu, so nampak kelam kabut. So there's not a problem from there, right? So tahu lagi nak buy time, but time is already running out in respiratory examination, right? Either you buy your time or you buy another 6 months time macam tu lah. And then you pegang stethoscope macam ni, tangan make sure you hold patient shoulder, right? You give more confidence, you give more reassurance to the patient. You can have some support also, jangan tekan sangat, just hold the patient shoulder, right? Sama juga masa you have someone tengah sedih, right? Dia pegang bahu dia, something like that, right? So same thing, just to keep the patient calm and you can build more rapport and trust with the patient. Jangan ambil kesempatan sudah. And then make sure you hold macam ni. Jangan kepit, and then make sure your hand tak cukup pinggang lah. Memang masa annoying, masa examination buat macam ni. Dalam poket lah. So it happened many times. So this is not something that I made up, but something that really happened multiple times from the various students we was international and local, sama saja. Tak ada different. Okay. And then you move on to the posterior part of the examination. You repeat the same thing, but make sure for the posterior part you position the patient properly, right? If you do not position properly, you might get limited exposure. So what I mean, ask the patient to sit upright, right? Tak boleh nak 45 degree kan, kena duduk macam ni. Let's say you nak examine from the back, right? Tak boleh nak buang macam ni. You kena memang 45 degree macam ni, right? You ask the patient to turn the body. Ataupun senang sikit, you ask the patient to put the leg kat luar macam tu. So that you have good exposure. You put a pillow with the intention to make sure the scapula exposed adequately. Bukan letak pillow atas kepala dia. Bukan letak pillow, letak macam ni, letak pillow so that the scapula rotate externally and outwardly. Right, so that you get more exposure over the exposed area for you to examine properly. Kalau you just letak the pillow macam tu, as simple as on the patient lap, ataupun letak macam biasa je, letak macam ni. Bukan macam ni. Right, let's say this is 45 degree. So dia kat baju. Ini tak boleh sebab dia bukan manusia betul. So we cannot. Dapat patient. Okay. Tak boleh. This is not how you position the pillow. You ask the patient to make sure hard from the back macam tu, right? So that the scapula ni, that's the idea. Scapula ni dia expose more area for you to examine. If not, then the area that you examine later on will be on the scapula. So you get wrong finding. You can reduce breath sound and so on. Where patient actually has a good breath sound over this area. just that you do not expose forward. And then make sure this is the position. You can put the patient perpendicular to you, and then after you complete examination, you can follow by straight away for the cervical node assessment. Kalau ada masa lagi, check for axillary. Then last not least, the erythema. Okay. So far okay kan? So far okay. So far okay. Habis dah? Tak ada. Dah buat Okay. The next step is to present your findings. This is the most, I think the most, not really the most important. If you do not get a good finding, then susah nak present. But make sure you know how to present your finding properly. At this point of time, you already left with 87 days. 85 days, right? 85 days before you're sitting for your final exam. You must already have an idea on how to present a short case finding. For every possible findings, let's say for respiratory illness, as I mentioned, there are few only possibilities: pleural effusion, consolidation, collapsed lung, bronchiectasis, ataupun lung fibrosis. That's it. Sometimes you can get lung emphysema. So you must have an idea on how to present a case of, for example, pleural effusion. How to present a case of bronchiectasis. What are the things that you need to mention? Of course, the principle is the same: condition, cause, complication, but you have to fine-tune to every condition. For example, you have a case of unilateral pleural effusion, right? That was right. Bear in mind when you want to present your findings, always finalize the finding. Anterior posterior should not contradict into each other. Always mention, divide the lung right and left, upper, middle and lower. If you are so confident about your findings only confined to the one side of the lung, mainly the right lower zone, you mention straight away during your opening statement. I can conclude that from my physical examination or my respiratory examination, I can conclude that my finding only confined to the right side, right lower zone, which is suggestive of right pleural effusion, as evidenced by 1, 2, 3. As evidenced by reduced chest expansion of a right lower zone, reduced vocal and diaphragmitis, tonitanus of percussion, and apa dia lagi? Apa ni? Cukup lah kan? Tonitanus of percussion, which is suggestive of pleural effusion. And the likely etiology for the right pleural effusion could be due to bacterial pneumonia, pulmonary tuberculosis, lung malignancy, based on the others probability. I would like to confirm my finding by doing such and such. As simple as that. Let's say you get a finding of right upper zone collapse lung, right upper zone collapse lung, right upper zone, for example, right. Post TB you dapat lung scarring, lung collapse, right upper zone. Senang patient TB dapat. Patient TB biasa dapat right upper zone collapse lung. So you can mention, from my examination, I can conclude on my finding for this patient only confined to the right upper zone, which is suggestive of right upper zone collapse lung, as evidenced by shift of the trachea to the right side, and then reduce chest expansion over the right side, reduce breath sound, a dullness of percussion, and reduce tactile and vocal parameters, which is suggestive of right upper zone collapse. I would like to confirm my finding by requesting chest X-ray to look for evidence of lung collapse. I would like to do lung. Macam mana you tahu? Simple je, cuma you kena ada script. So what I did in the past, I record, because I have to go through your period also. Yang ni I tak kena go through. I kena go through kat dulu pun sama je. Nak doctor, right? So you kena go through this same period that I had in the past. So what I did, mula-mula buat, because English is not my first language, right? So sometimes for those of you who have problem with language, you are not a good speaker, for example, right? So I say for what I did in the past, I tulis dulu a script. Macam let's say you just imagine yourself that you tulis dulu. Let's say you have a case of pleural effusion. How you should present the case of pleural effusion? You buat script dulu. ChatGPT kan ada sekarang, right? So you tulis ChatGPT. If you're not sure, you tulis, then tulis improve my writing center for you, right? Pernah buat kan? Okay, so simple, right? That's why bila tengok balik you punya case write up, aduh my god, you punya bahasa ni. Bila tulis tangan memang tak boleh guna ChatGPT, right? Nampak SM up, you can use your ChatGPT, right? Because your handwriting, right? Nampaklah keluar kabut sikit bahasa tu. Okay, simple as that. So you prepare a script for every possibility of for cardiovascular pun kena prepare. For MR, how you should present for MR with or without complication macam tu. For abdomen pun you kena prepare the script. Then you record yourself. I think balik my recording paling malu ni. Jangan share, can you share to me? Jangan share, malu tengok ada ni. Always when you look back to the what you record, senang je tengok, you audit balik. So I learned this, kalau you familiar dengan ada one Vietnamese speaker yang dia stay dekat Australia, Vin. Anyone of you familiar? V-I-N-C-H kan nama dia? He's a good speaker. So what he advised for you to improve your communication is that you record dulu. You record, then you audit. Right, you record, then you audit. So you can do the audit 3 things. First, you record, of course you record everything, right? So first thing you record, you audit in terms of you just listen to what you say. Tak payah tengok video, tak payah guna mata apa benda, just listen. What you like about your presentation and what you don't like about your presentation. Either the content, either the sound that you make, or the sound lah biasanya, or additional non-words that you add on during your presentation. Second thing, you audit in terms of your body gesture, right? Your body gesture, you just tutup sound so they can focus. Tengok balik, your hand movement, your body gesture, what you like about your body gesture and what you don't like about your body gesture. Macam tu boleh improve yourself. And last kali, baru you audit everything. The sound, your facial, third one is your facial expression. Tak payah tengok lagi tangan, just tengok your facial expression, whether you maintain the eye contact or not with the audience, right? Because you're talking macam ni susah ni, takkan nak fokus kat Yvonne, kena Yvonne je. Takkan nak fokus one person, right? You kena tengok atas, bawah, atas, bawah. So that yang tengah tidur pun nampak ke belakang tu. Yang baru nak tidur pun you tahu. So dia akan wake up, Yvonne akan sedar that your talk is already almost 1 hour already. Okay, so you have to do a lot of audit so that you can see what are the improvement that you can do so that the presentation akan nampak more professional, nampak natural as well as concise enough. You are not going around the bush during the presentation, right? So susah nak beritahu one by one presentation. Cumanya, as I mentioned, you try to record yourself. Then you tengok which area to improve from your presentation. The presentation, I really advise you not to do a live commentary, because the moment you say during your live commentary, certain examiner, okay, if you want to do a live commentary. But for me, and then for some, I think most majority do not prefer students to do live commentary, because the moment you say the findings, you cannot retract. Sometimes you have discrepancy, discordant findings between peripheral, anterior and posterior, right? So difficult for you to defend yourself. So my advice really for you to take your time after you completed your examination. You take your time, about 15-20 seconds, to gather all your thoughts and then to process the information and then present the findings to narrate the findings toward your desired diagnosis. So salah tu nombor 2. You present dulu, right? Jangan bagi contradict finding. Contohnya, when you present the finding, you get a case from your finding, from your examination, it sounds like a pleural effusion, but you bagi diagnosis, lung collapse. You bagi diagnosis, COPD. You bagi diagnosis, lung consolidation. It does not tell you. For example, you have a case of right pleural effusion, right? Reduced chest expansion of a right lower zone, spondylitis of percussion, reduced tactile and vocal parameters, right? Which is suggestive of right pleural effusion. And then, tadi you mentioned, based on the finding, I can conclude that these findings are consistent with right lung consolidation. So tak consistent lah you punya finding. Tak tally your finding, your clinical diagnosis with your clinical findings, right? You kena tally kan. Kalau tak tally, kena check balik what is wrong. So far? Okay. Any question? Ada sedap. Any question? How many more groups tak buat lagi showcase recipe? Ada satu group lagi kan? You already done with one more rotation, right? One more rotation, right? Then 4 weeks of break, then exam. And tak break, right? You ada your semester exam first, then 2 weeks final pro. Don't worry so much lah. I think because even though you have to prepare a lot in your, I personally rasa the system is not fair to the medical student, because my system I graduated from training program Penang and Dublin punya training program. I did my clinical years in Penang, so I had exam for every single system. For internal medicine, I had the short case, long case during as a final pro. So I have to prepare. There are weeks for internal medicine and surgery. Also, I have to do MCQ, OBA. It's not one paper, banyak paper. So there's a lot of exam. But at least I can focus one at a time. For internal medicine, 1 week, right? Written, OBA, and then short case, OSP, and then long case also for internal medicine. And then next week for surgery, next week for orthopedic, then for gynae, for ONG. So there's a lot of exam, tapi at least you can focus. For you only exam tak banyak question, right? One paper covers everything. You have to think in many aspects, right? Kejap jadi psychiatrist, kejap jadi pediatric. Kejap you are not sure. Topik ni medical ke ONG ni sekali, right? Entah sajalah. Sama. So be unfair, but you tak tahu kenapa, but that's how it is in USM. Then I see tak nampak macam nak change in the nearest time. So bear with it lah. Kalau kena extend pun next year macam tu juga. So any question? Okay.
Okay, so the question is that, so usually in short case, usually it will be given in a case scenario kan doktor. So contoh of case scenario, this patient will be presented with shortness of breath. So how do we know that we have to do cardio examination, or is it a respiratory examination, or do we do both?
Dia tak tahu. This is your respiratory station. They are not going to confuse you. Don't worry. This is the respiratory station. But for three main cardiovascular, abdomen, and respiratory examination, they are quite the instruction quite stereotype. Some of the instruction. For respiratory, this patient presented short of breath, but comfortable your patient, but that's how the narrative story. This patient presented with short of breath, but this is your respiratory examination. Dia akan ada follow-up question. Please do a complete respiratory examination. Don't worry about that. But for neuro, you have to be more careful, right? Neuro banyak set, right? Banyak set of question. You ada motor examination, cranial examination, eye examination, gait assessment. Ada speech assessment banyak sangat. So listen to the instruction carefully. Sometimes for MMed lah master, for undergraduate usually we do not kejam sangat. For master students senang. Look at this patient and proceed. Dan tengok tak tahu nak buat apa. Tengok normal everything, nak tengok apa, right? And then you ask, sometimes can get also stamp. Please assess this patient gait and proceed. So the next step what to do depends on your gait assessment. From the gait assessment, tengok patient ni ada macam ataxic gait, right? Nampak macam cerebral punya gait lah. So you have to demonstrate all the cerebral sign and then all the relevant sign. So let's say from the gait you nampak circumduction punya gait, nampak jalan macam ni, right? Macam stroke. So the next step to do is to do motor assessment. So let's say from the gait assessment, tengok nampak macam Pakistan jalan small step, shuffling and all. In block, then the next step you have to do is to assess for Parkinsonism. So for CNS, you have to listen carefully for the instruction. But for other system, I think quite straightforward lah. Tak boleh lain sangat. Please examine this cardiovascular system. Regardless the opening statement, this patient presented with cough. Please examine the respiratory system. Sama je. This patient presented with short of breath. Please examine the respiratory system. Sama je, the set of examination is the same for three systems: abdomen, cardiovascular, and respiratory. Similar stereotype macam tu je, tak ada special. But for neuro, banyak, you can get anything. Right. Any more question? Yes, unless the examiner dah malas, just focus on the other, the ujung-ujung. If the last candidate, right, just focus on the anterior part only. But pattern we dah confirm. Ada point dia ke? Ada one point for the last year, abdomen system. Yang fail lah, COVID itu memang fail lah. Saya tu untuk shock you know. This patient abdominal system. So straight away dia examine abdomen terus, kerana tak dapat finding pun. So as a general rule, unless the instruction given clearly, just examine the abdomen. Then examine the abdomen. If the instruction given respiratory system or abdominal system, you start from the periphery. You go periphery or you go to the main organ. Jangan start from the main organ then go to the periphery. Any more question?
If in the exam, is there possible we have like one demo finding? Means like if it's given like there's finding of bronchiectasis and also pleural effusion or bronchoasthma patient is like complicated with other pathology.
If as a minor, usually those yang cari cases ni adalah training lecturer ataupun master student. Usually the instruction given is to find question with one finding, the unilateral or one single finding. But if you couldn't find any patient with one finding, ada double pathology pun sometimes kena juga, dah depends lah. But for master student usually two or three pathologies. But for undergraduate, remember for undergraduate punya exam, you are meant to pass the exam until you fail yourself. But for postgraduate, you will fail until you prove that you belong to the fraternity. So a bit tough from there. So, but for undergraduate, theoretically dah masuk patut keluar sebagai medical student, sebagai experimental as a houseman. But if you fail yourself, then you cannot help lah as a medical, as a you're supposed to graduate because we select you to be in the system. You are not here by chance. Okay, any more questions?
In terms of discussion, would it be the same like your case
Discussion, we just 10 minutes. One short case session consists of 15 minutes altogether. 10 minutes is the time that you need to complete your examination. Usually when you present your finding, you already use up 2 minutes. You are left with 3 minutes. So the next subsequent discussion very much depend on the remaining time. If you are stuck with the findings, so discussion akan banyak. But I really advise if the examiner do not stop you, you just present by management. For example, you have a case of COPD, right? You can conclude this is a case of I have completed my respiratory examination. For this gentleman, I can conclude this is a case of COPD. Current status in exacerbation preceded by pneumonia as evidenced by consolidation of the right middle zone. And current status patient in respiratory failure. I would like to confirm my finding by requesting chest X-ray to look for evidence of hyperinflated and as well as evidence of consolidation, to look for ABG, level of degree of respiratory failure, type of respiratory failure, sputum CNS, and so on. Right, then I would like to offer the patient with nebulizer, so. I would like to start the patient with inhaler, so. Just straightly masuk, straightly bagi your plan. Do not wait until the examiner prompt you. So sometimes after you present finding, you tunggu examiner tanya, right? So nampak apa your patient ni? So what is the next step? If you have time, if the examiner do not stop you, then you just continue. You are already on the right track. If you are on the wrong track, of course examiner akan stop you straight away from that. Tak payah queue lah, kalau dah kena stop tu, examiner salah. Okay, any more question? Ada soalan lagi ke? Sebelum yang final pro, nampak lagi final pro ni. Ada soalan lagi? If not, then good luck. I think you have class with Prof tomorrow, right? What is going to be the format lah? Someone present macam tu. Someone present dan kena hentam. Ada Prof tak? Ada memang sekolah besar dia. You present dan hentam sampai dia pun kena yang I think kalau nak minta dia buat showcase session hari for dia kan, Muhammad. He's a good teacher, he's a really good mentor. He's my mentor and a friend as well. Kalau fortunate lah ni, Muhammad Fauzi and Faizani during combined American. But suara dia kuat lah kan, suara dia kuat. He doesn't need a microphone. Okay, make sure for him to beli coffee. He loves coffee. You buy coffee for him kalau ada kelas tomorrow. Kutip dah 50% orang ke, you buy coffee, no sugar, and the fry, right? No coffee for him. Okay.